No,
Okay.
it sounds.
All right. Good afternoon. We're going to get started now. I'm having to use the handheld. My apologies, but we're having some technical difficulties back here. I'm Karen Carr, and this is Carly Croft. We're the Grand Rounds coordinators. As you can see, Dr. Berkman is not here today, but we are happy to present the Grand Rounds session for today, Thursday, January 16th, 2025. We are currently holding grand rounds in the Molecular Medicine Research Building at 1220 East Broad Street. So for those of you who are trying to get CE credit in attendance, please note that the QR code is here. It will be here for a few minutes prior to us getting started, and we will show it again at the end of the session. So if you guys would please silence your phones before we get started, I greatly appreciate it. Today, we are pleased to have our second CPC for this Grand Round season, and it will be presented by our Chief Resident, Ramez Bodair. So Dr. Bodair, coming from Palestinian origins, Ramez grew up in Qatar. He attended medical school at Weill Cornell Medicine, Qatar, branch campus of the New York-based medical school, graduating in 2021. He then moved to Richmond to begin his residency in internal medicine at VCU. After completing his residency in June 2024, he now serves as one of the chief medical residents in the Department of Internal Medicine. Ramez is very excited to start his cardiology fellowship at Cook County in Chicago in July 2025. His career interests include general non-invasive cardiology with an interest in medical education. So if you please help me in extending a warm welcome to Dr. Ramez Bodair.
Thank you very much, Karen, for the warm introduction. Good afternoon, everyone. I'm glad to see everyone here in this venue, especially after the crisis of last week. I'm very excited to share with you this interesting case, and even more excited to have our case discussant and faculty speaker to crack through the case. This is going to be our format. I'll start for a few minutes to talk to you all about the case, followed by our case discussant, Dr. Sastry, who's going to go over the diagnostic approach for the case. And then our faculty expert, Dr. Sangeeta Sastry, who's going to reveal to us the final diagnosis. Just a reminder of the overall goals of CPC. We're here to identify key components in patients' data on presentation, generate differential diagnosis, and use evidence-based medicine to support the diagnostic approach in medicine. So our case for today is going to be about a 63-year-old who is presenting with fever and myalgia. So we have here for the history of presenting illness, a 63-year-old gentleman with medical history of hypertension who presents to the ED with fever and myalgia. He tells you that his symptoms started 5 days ago prior to the presentation. He was visiting his brother in Virginia on the day his symptoms started, and he normally resides in New York. He started having fever, diffuse body and joint aches, and malaise prior to his presentation. He was given amoxicillin, gabapentin, and acetaminophen, which provided no relief to his symptoms. His symptoms became progressive over the past 5 days, and on the day of the presentation, he was so weak that he fell from a chair, which prompted him to present to the ED. He shares with you that he had similar symptoms years ago, and his diagnosis was treated appropriately with complete resolution of his symptoms. He feels that he might be having the same diagnosis, and he's requesting to get treated for it. Upon review of system, his review of systems is notable for chills, fatigue, and fever. His musculoskeletal review of systems notable for arthralgias, back pain, and myalgias. And for his neurological review of symptoms, notable for dizziness, syncope, which when he fell from the chair, weakness, and lightheadedness, in addition to sleep disturbances. Otherwise, complete review of systems for him was unremarkable. For the rest of the elements of the history, his medical history notable for hypertension and peripheral neuropathy, past surgical history with remote hemorrhoidectomy, family history, nothing that was remarkable on presentation. And for his social history, he lives in New York, as mentioned earlier. He's originally from Senegal, travels there 3 times per year. He returned from his last travel a week before his presentation after spending 2 months there. He recalls no exposure to freshwater, wild animals, insect bites, or sick contacts. And he is a non-smoker, does not drink alcohol, and does not use any illicit drugs. Does not have any known medical allergies. And for his medications, he takes as needed acetaminophen, daily amlodipine for his hypertension, vitamin B12 supplementation, and gabapentin 3 times per day for his peripheral neuropathy. So for his objective data on vital signs, notable for tachycardia with heart rate of 100 and fever with temperature of 38.3 degrees Celsius. For his general examination, he appears to be ill and fatigued, otherwise nothing remarkable. His HENT examination was unremarkable. For the cardiovascular examination, he was having tachycardia with regular rhythm, otherwise no added heart sounds. And for his respiratory physical exam, nothing was remarkable for him, and he was not in respiratory distress. For the rest of the physical examination, his abdomen was soft and non-distended with no notable tenderness or organomegaly. His extremities were warm. No rashes were appreciated on his skin. And for his neurological examination, he had decreased sensation to touch over thumb and the first 2 digits of his right hand. He also had weak but symmetric grip strength bilaterally. Otherwise, the rest of his neurological examination was unremarkable. Moving on to his labs, for the chemistry is notable for mild hyponatremia with a value of 133. For his bicarb, it was low at 19. He has decreased renal clearance at a value of creatinine of 2.49. We don't have any known baseline for him, but it's presumed to be normal given the unremarkable medical history. He also had elevated BUN at 34. For his hepatic functional panel, notable for mildly elevated ALT at a value of 70 and hyperbilirubinemia at a value of 3.1. His CBC notable for hemoglobin of 9.2, which is presumed to be acute for him given no known diagnosis of anemia. His white counts were fine, and he had thrombocytopenia at a value of 52. Other notable labs for him, his fibrinogen was within normal limits, his coagulation panel all within normal limits. He had a mildly elevated LDH at a value of 367 and normal haptoglobin at a value of 105. Other labs that were obtained for him, he had a really high ferritin at a value of close to 4,000. His iron was normal at 32. Transferrin was normal, and transferrin saturation was low at a value of 10%. In addition to all of that, he had an elevated lactate at a value of 2.4. For his urinalysis, on dipstick, notable for 100 of protein, 75 of leukocyte esterase, and negative nitrites. And on microscopy, he had 2 squamous epithelial cells. His respiratory pathogen panel was negative, his HIV test was negative, and his blood cultures were negative at the time of presentation and even later on during his hospital stay. And then lastly, he had a chest X-ray, which was fairly unremarkable. Lung fields look fine with no consolidations. No pleural disease is appreciated, and his cardiac silhouette appears to be normal. Eventually, the diagnostic test was obtained for him and the diagnosis was made. And that's what I have in terms of the case for you all. Now I'm honored to introduce our case discussant, Dr. Sarah Street. Dr. Street did her PhD and MD in that order at the University of North Carolina at Chapel Hill. In the years between her graduate work and starting medical school, she was a research assistant professor in the Department of Cell Biology and Physiology, and she directed the first-year medical students' human physiology and neurobiology course at UNC School of Medicine. After working with medical students and physicians for 5 years, she decided to apply to medical school to facilitate a career in medical education and patient care. After graduating from medical school at UNC Chapel Hill, she did her residency and chief residency at Massachusetts General Hospital in Boston, Massachusetts. She continued on at the combined Brigham and Women's and Mass General Joint Nephrology Program for fellowship. Her prior research focused on immune checkpoint inhibitors and kidney disease in patients with urologic cancers. She's interested in medical education and mentorship at all levels of medical training, and specifically developing curricula focused on clinical reasoning skills. With that being said, please welcome Dr. Sastry.
Awesome. Well, it is great to be here, I think. It has been absolutely wonderful to be at VCU. That is for sure. I've been here for 6 months. And it's crazy how even in 6 months, I recognize so many faces out in the audience. And it just goes to the whole reason why I came back south is because I wanted a place where people are friendly and warm, and I could meet a lot of people and have a lot of great relationships, and that's been true. I've also had a great time working with the learners at all levels. I just came off a great 2 weeks on general medicine, where we had a great team led by Matt Dean. We had gave a lot of really quality care, and I just had such a great time working with some stellar interns, and I'm excited to do that more and more. So thankful to be here doing the CPC. If I'm honest, as a medical student, one of the things I did was I never missed a CPC in the New England Journal of Medicine. I read every single one. It was not an insignificant reason why I chose to train at Mass General Hospital. And the moment I got there, I hardly read any more ever again. It's hard to do that in residency. I fell off the bandwagon. And also, I'm not lying at all. When I was hightailing it out of there, I did think to myself, thank God I'll never have to do a CPC, or at least the probability is much less by not being there. And lo and behold, here I am standing in front of you, being here for 6 months doing a CPC. So I am thankful for this opportunity. I think we'll see how this goes. I am totally obsessed with clinical reasoning, and ultimately that's what CPCs are all about. It's how to talk about how we think through cases, and I'm very excited to have this opportunity to do so. So let's get to the case. So approach to clinical reasoning. Everybody has their own way they approach cases. For me, I have used and have developed a curriculum around the Journal of General Internal Medicine's Exercises in Clinical Reasoning series, wherein they have attempted to define and use, well-researched and accepted terminology that are defined approaches to how we think through cases, including developing problem representations to help us organize our problem space, which is just another way of saying all of the possible differential diagnoses within a certain problem representation. Using diagnostic schema to organize our thoughts to make sure that we're not missing anything, and then looking for the highest probable diagnosis based on illness script matching. So that's some of the terminology, and that I'll be using today. We'll kind of talk about those as I go through the case, and also just to kind of organize my talk by this. But before we do anything, obviously the most important thing, whether you're doing research or a clinical reasoning problem, is you have to organize your data. You have to figure out what's there, what you're going to pay attention to, and what is going to lead you down the most interesting paths. And so we're going to do this after Dr. Bodair has taken us through the case. So we're going to start by just the subjective parts of the case. And we have a patient who's presenting with fever, myalgia, body aches, and malaise. So that is our chief complaint. And I have the opportunity to decide what of that I'm going to take with me. And again, I'm looking for key differentiating factors that are going to push me in one direction or the other. Fever definitely limits what I'm going to be able to think about. It is more of a limited differential diagnosis. whereas myalgia, body aches, and malaise, sometimes I have those on a daily basis. So it's hard, like those are really not key differentiating features. They can follow with fever, so I'm going to kind of let those fall back to the background, and I'm going to focus on fever. That's our chief complaint. Then we hear that he has been having this for 5 days and it's worsening. And it's worsening to the point where he's falling out of his chair, he's got back pain, and then he has this numbness in his bilateral upper extremities in the first 3 digits. It sounds to me like that's been going on for quite some time, like 3 or 4 months. So that is not really those are 2 different tempos. So I have to decide what's bringing him in right now and what is the tempo that I'm going to go with. Is this a more of a subacute to chronic process that's coming in, or is this more of an acute process? And I'm really going to focus on that 5 days of worsening, and I'm going to define my tempo as being an acute progressive tempo. Next, we hear that he is both from New York, and he recently returned from a 2-month trip to Senegal about a week ago. That tells me who my patient is. He's a patient that has recently returned from travel. And then there's this little interesting tidbit that he's experienced similar symptoms in the past that was treated with a definitive treatment and led to a complete resolution. So I'm intrigued by this, okay? I want to be like, yes, this is something that's very highly significant to the case. I did some research around symptom recall. As it turns out, it hasn't been highly researched enough for me to be able to say, this is really predictive. It has a high sensitivity when people remember their symptoms from a previous case. It's just not that good, or else we just don't have that much research into it. But I'm intrigued because, as I said before, fever, myalgia, body aches, not super specific. And so why would you come to the hospital saying that this reminds you of something in the past when you had a treatment for it and you're worried you have it again, unless there was something else about this presentation, something else about that fever, or something else about the relationship of that fever to another event that made it stand out in his mind. So while we don't have that information, I'm intrigued. Is there something about this fever? Is it cyclical? Is it really, really high? Is it accompanied by some other symptom? Or is it accompanied in time to some other event that he remembers clearly, perhaps one of these trips to Africa in the past? Finally, so this is symptom recall. Was there something special about that? So finally, we have this idea that he's like saying, I don't remember any exposures, which, you know, as an ID doctor, you're always looking for those exposures. And here's a patient saying, I don't remember any of this stuff. So my next question is how much should I pay attention to that? How much do patients remember how much do they really remember their past exposures? Well, it turns out it depends on what exposure you're talking about. Insects, not that well. There has been some data that looked into mosquitoes, but really some of the best data in this is surrounding tick bites. Again, I just got done training in Boston, so it was hammered into our mind. People don't remember tick bites, even though, so when you see a rash, that looks like erythema marginum, then you have to really think about that. And there's an early study that showed that only about 25% of people remember their tick bites. As it turns out, nomadic Mongolian herders do a little bit better than we do in the United States. They're up in the 60%, maybe almost pushing 70%, but still not that great. What about other exposures? Fresh water, a little bit better. You remember when you went swimming. So maybe you get a little bit better of an exposure history if someone went swimming and you're looking for freshwater exposures. Here's a study about acute schistosomiasis. This happened, 27 people remembered going swimming, and of those 27 people, 22%, and all the people that actually had schistosomiasis, so 100% remembered that they connected that freshwater swimming experience. So hard to say. If I'm thinking about a freshwater exposure, I might give them some credit for not remembering. Insect bite, I'm probably not going to tell it. I'm not going to be like, I'm not interested in any, I'm not going to drop all possible insect-borne illnesses off my differential. All right, so there we go, sorting through subjective. Let's turn to objective. First off, he actually is febrile. How many times has somebody come in reporting a fever, only to never fever again in the hospital? So this confirms, I believe that he's been having fevers. I believe that he's having them for 5 days. And I know that they're high, but they're not like extremely high, or at least this one here is not that extremely high. So confirmed fever. What about this weakness? So the only real focal findings on exam are this unilateral median nerve deficit, and it's cutaneous, and then maybe some motor weakness that's bilateral. To me, those don't map anywhere, and they're maybe more associated with this more chronic issue that he has. So I'm going to call this not acute weakness. And I will say right here on the outset, this is where I start to diverge in my differential. I'm going to turn away from a specific complaint that he has, and I'm going to really put it into the background, recognizing that I might be doing so at my peril. But I don't think that this is not the tempo that he's coming in with. So again, I'm going to say that this is more chronic. Then my favorite part, I'm a renal doctor. I noticed this AKI, oh fun. So, but the thing is, I kind of pull myself back because the kidneys often in febrile illnesses are along for the ride. It's rare that the kidneys are going to drive a febrile process, although it can happen. So again, I start to make a differentiation, a decision in my diagnostic process that I'm going to, instead of saying that this is an acute renal process that's driving the whole presentation, I'm going to say that the kidneys are along for the ride and they're traveling along with this mildly decreased global perfusion, a lactate of 2.4, as well as this metabolic acidosis. And I'm going to call this early end organ damage and maybe some signs that there might be some shock, which tells me about the severity of his disease. Finally, there's all these lab abnormalities that include a mildly elevated ALT, a hyperbilirubinemia that is a T-bili. We're not given direct or indirect, probably for a reason. A normal alk-phos, which is interesting. And he has an anemia and an elevated LDH. These things travel together. And normally they travel together as hemolysis, except there's one problem with this. He has a normal haptoglobin. Normally, when people have hemolysis, you're going to have a low haptoglobin. So how much am I willing to go to group these together as hemolysis with a normal haptoglobin? Well, I'm going to take that haptoglobin in the context of another lab value, which is that towering ferritin of nearly 5,000, showing that we have a high acute milieu. Haptoglobin is also in the acute phase. It's acute phase reactant. And a normal haptoglobin is is not concordant with that high ferritin, meaning that you would expect it to be higher. So the fact that it's normal to me might argue in favor that this might be hemolysis. So I'm going to, again, make a decision that I'm going to group these together as hemolysis rather than liver dysfunction. And a lot of that also is supported by the fact that we don't really have super high towering transaminase elevation, and he has a normal alkaline phosphatase. If it was something that was causing biliary obstruction, especially lower, I might expect an elevated alkaline phosphatase. So I'm going to call that hemolysis. And finally, I'm going to group this normal haptoglobin in the context of a towering ferritin together, and I'm going to call that acute inflammation, okay? The rest of the data is this normal fever workup that we get here, and all that's telling me is it ain't nothing easy. Okay, so not bacteremia, not a pneumonia, not a UTI, so I got to go look for something different. So what I'm going to do now is take all of those findings and I'm going to put them together in a problem representation, which is a very specific, comes along with a very specific definition, okay? A problem representation, and I've really started to push all my learners to develop one of these things before they jump into any other part of their presentation. It has three parts to it: who the patient is, what the what's the tempo of the presentation, and then finally, what is the clinical syndrome? And really effective problem representations help us to put this data together in a way that our minds can then start to match those illness scripts. And they will focus on the most differentiating and distinguishing aspects of the case, which is why I'm not going to pay attention to the backaches and malaise and myalgias that I have on a daily basis. I'm going to try and consolidate as much of this information as possible as clinical syndromes using medicalized terminology that my brain is going to recognize. So with that, this is my developed problem representation. This is how I'm putting the case together. We have a 63-year-old New York resident with recent travel to Senegal who presents with an acute progressive febrile illness found to have evidence of hemolysis, thrombocytopenia, acute inflammation and early end organ damage, resembling a previously treated and completely resolved illness. Okay, so with that, now I can start to do the work of narrowing down the problem space. And one of the ways I'm going to do that is to generate a diagnostic schema, one that I might have learned before. But in theory, I could choose any part of my problem representation to make that diagnostic schema. I could base it on hemolysis. I could base it on thrombocytopenia. I have diagnostic schema for both of those things. But instead, what I'm going to try and do is narrow it even further by using two of this parts of my diagnostic schema, fever and in the returning traveler. I have a diagnostic schema for that, so that's how I'm going to organize the rest of my clinical reasoning process. So I'd like now to go through my diagnostic schema for a fever and returning traveler. So based on this, people can have fever based on many different illnesses. I'm going to group them into something that was acquired on their travel that was related to their travel, in this case to Senegal, or something that was acquired at home. If it was based on an exposure to Senegal, usually we're thinking about infectious diseases. So I'm looking for some type of microorganism. So I want to think about all the possible causative microorganisms that can cause fever. There's viruses, bacteria, parasites, helminths, fungus. This is just a general way we think about infectious disease. It also could be due to some type of infectious etiology that was acquired at home. So again, I can't just automatically exclude things that happen back home. I have to think about those things as well. And also fever is related to things that are completely not infectious. So I also have to think about things like malignancy, drugs, and rheumatologic causes of fever. So at the end, that is still an extremely large problem space. And I don't want to have to think that big about all those different possibilities. This is like just to make sure I don't miss anything, too big. So I'm going to return back to my problem representation. I'm going to see if there's anything else in there that I can use to then kind of narrow that even further, to get even more specific into, is there a little part of that that might narrow my problem space down to a workable differential? And so I'm going to pull in this idea of hemolysis. And again, this is a diagnostic turning point in my reasoning. I could have chosen something else entirely, and it might take me in a completely different direction. For me, one of the hard things about this case is there's a lot of information in there, and a lot of it really isn't super distinguishing. This idea that hemolysis might be one of those things that is, so I'm going to go with that. So now when I turn back to my diagnostic schema, and I have this idea of hemolysis or hemolysis mimics. I want to make that important too, because I don't know that this is hemolysis. I know that there's high bilirubin, but I don't know if it's direct or indirect, so I have to consider hemolysis mimics as well. I'm now going to do this, go through my diagnostic schema, and this is a much more workable differential. So as far as viruses, I might consider dengue, chikungunya, or yellow fever. With bacteria, there's tick-borne, leptospirosis, and typhoid, parasites, malaria. But I also have to think that he's been back in the United States for 7 days. He came from the United States originally. So I have to think about things that could be happening there. And again, this is my bias. I just came from the Northeast. If a person comes in MGH with this, it's Babesia every time. So I have to think about Babesia. And then also, I'm a kidney doctor. If I see thrombocytopenia, hemolysis, and an AKI, I'm going to think about TMAs. And I have to consider this because while they might be lower on the differential, they're both can't miss diagnoses because they can kill somebody. But they also have definitive treatments that can save somebody's life. So I have to include them into my differential. All right, so here we go. So now there is one possible wrench in my reasoning, and that is if this person, this is a first presentation of G6PD, back to everything's on the table again. Everything infectious is on the table again. And as it turns out, I just wanted to say, like, what is the incidence of G6PD deficiency in populations in Senegal? It turns out among some ethnic groups, which we don't know anything about this particular patient, they can have up to 12%. CPCs are hard. I was told by Mary Del Baggett, who puts them all together at MGH, they have to be gettable. So this would be pretty tricky. I'm going to assume that that's not what we do here. So I'm going to back myself up out of this possible caveat and assume that that's not what's happening. All right. So to my differential now. All right, so I'm going to do these as I've seen CPCs done. They tend to be done in reverse order so that you end with the thing that you think is the most likely. So here's my differential in reverse order of what I think it is. First off, got to consider that TMA. What argues in favor of it? Well, he's got this AKI, possible hemolysis, thrombocytopenia, and fever can be present, especially in TTP. It's one of those big five that we actually never see in TTP at all. But theoretically, fever could be there. So, but what argues against it? Well, the T in TMA actually argues against it. There's not a whole lot of evidence of thrombosis. Has no abnormalities in any of his coags. He had a normal PT, a normal PTT. There's no focal neurologic deficits. He has this kind of symmetric peripheral nerve motor neuropathy, but again, that would be really odd to have. The probability of having two thromboses exactly knocking out your median nerve would be probably pretty hard. And he has no report of he certainly could have E. coli or something that could have caused hemolytic uremic syndrome, but there's no report of diarrhea. So again, I don't think that it's this. I'm going to say this again is not a primary renal issue, and I'm going to now turn to infectious etiologies. So chikungunya. I'm going to kind of show a map of just because if I'm going to invoke infectious disease, I have to invoke infectious diseases that are either somewhere where the patient has been. So chikungunya here is Senegal for anybody who may not know that. That's Senegal right here. So that's where we're looking on all these maps. It's there. So again, this is not one that's it's kind of pretty low on my differential, but these body aches being such a prominent part of it, and this kind of maybe some neuropathy could be part of it. So I have to just bring it up. What argues in favor is this joint pain, but there's a whole lot that argues against it. Namely, thrombocytopenia is usually not as severe, not down to 52,000 like we have in this. Hemolysis is pretty rare. Normally, chikungunya follows with a rash. And there's also kind of going back to what made this person come to the ED in the first place. There's no specific treatment because it's a virus. Again, I'm not going on that fully, but I don't think it's that. Next possibility, yellow fever. Again, it's where he's been. Things that argue in favor, high bilirubins. That's a prominent part of yellow fever. Thrombocytopenia is part of it. AKIs, evidence of shock, and then back pain, all could argue in favor of yellow fever, but there's a lot that argues against it. The hyperbilirubinemia is usually from liver dysfunction, and therefore it's not due to hemolysis. Hemolysis is actually quite rare. And also, again, it's a virus, no specific treatment. Next, dengue. Dengue is everywhere. It's getting more and more everywhere with global warming. So I have to consider that. Again, what argues in favor is this really kind of severe thrombocytopenia down in the 50,000. And also, again, this prominent muscle ache, also known dengue is known sometimes as breakback fever because of these prominent body aches and myalgias. What argues against it, again, hyperbilirubinemia and hemolysis, more rare, at least the first time around for dengue. He doesn't really report any headache, which, the people that I've known who've had dengue, they just all complain of how bad the headache is. There's no report of that. I don't know if it just wasn't picked up in the history, but I think that's usually a prominent part of that. And then you can have repeat infections of dengue. If you have it again, though, you have this enhanced immune response to it again, so it can actually be pretty bad, which, it's hard to know how to take that. He is presenting, on the verge of potentially getting really sick. But again, there's no specific treatment for dengue, so that wouldn't be consistent with his report of this very similar thing that's happened to him before. Tick-borne illnesses, you got to always think about ticks. So there are ticks in Senegal that can cause specific diseases. There's a lot of them, but they're kind of from what I can tell from the literature, it's kind of early on in how we're starting to think about these and really look for them in Senegal. Rickettsia africae, which is one of the vectors for rickettsia. Yeah, Rickettsia africae is one of the causative agent for African tick-borne fever. That's been identified in 20% of the vector tick in some rural areas of Senegal. And then Borrelia crocidurae, I'm going to say that's how we say it, but it is the causative agent of African tick-borne relapsing fever, and it is found in about 12% of the vector tick. So what argues in favor? Well, there's cyclical fevers in relapse or recurrent fever. Thrombocytopenia generally always follows with tick-borne illnesses and these really high inflammatory markers. But there's a lot of things that argue against it. It's still pretty rare, and it's mostly in the rural parts of Senegal. We don't know where he traveled in Senegal. He doesn't have a headache. Hemolysis, again, is very rare. Usually there's people are gonna like report an inoculation. SR, we didn't have any skin findings at all whatsoever. Fevers occur weekly, so if he just had a fever, like he would have only had one, you know, or maybe it's been going on for, so who knows. And getting a rare infection twice even is more rare, so I'm gonna kind of say it might not be tick-borne illness. Typhoid, okay, so hear me out. A lot of places, highly endemic in Senegal, high bilirubin, liver dysfunction. And the reason why I have to put this on here is pretest probability. If you look worldwide at fever in returning travelers, 18% of those people end up having typhoid. And so you have to think, I have to think about that just pretest probability wise. But there's a lot that argues against it. First off, no abdominal pain. He has a normal alkaline phosphatase, which again argues that what's going on and what's causing his high bilirubin is not really this liver stuff. And again, most of those 18% of the cases in returning travelers are actually from the Indian subcontinent, not necessarily from the continent of Africa. Not usually associated with thrombocytopenia as well. Leptospirosis. Incidence in sub-Saharan African is unclear, but one pooled systemic review found a seroprevalence of 12.7%, so it's there. Again, I'm looking for these hemolytic mimickers. So high bilirubin, liver dysfunction, renal dysfunction, thrombocytopenia, and these myalgias. But again, that hyperbilirubinemia is from liver dysfunction, not from hemolysis. No reported conjunctival suffusion or eye issues, no reported headache, no fresh water. Leptospirosis can be transmitted a lot of ways, but often we think about it as fresh water. Yeah. Babesia, I got to think about it because he's from New York. It's there. Again, this actually is more in what I'm thinking with hemolysis, thrombocytopenia. It's endemic. Repeat infections are common. 2-day incubation. He's only been back for 7 days and he had fever 5 days ago. 2-day incubation is too short and he's been gone. 8-week incubation is a little too long. So that brings me to finally malaria. So worldwide, malaria accounts for 77% of fevers in returning travelers. So from a pretest probability, this was malaria until proven otherwise, okay? I'm gonna kind of hinge on that. It has hemolysis, thrombocytopenia, back pain, high ferritin, repeat infections are common, and the fevers might be memorable because they are cyclical and they might be tied to this last time he was in Senegal. What argues against? Our great exams, great exam skills. There was no hepatosplenomegaly on exam, but I don't really know what to do with that. I don't think I've ever caught hepatosplenomegaly unless it's like, myelofibrosis or something like that. Patients usually present with that low haptoglobin, and in a CPC scenario, a high pretest probability actually argues against. So that's what's really kept me coming back is this malaria? Is this end up being the diagnosis, which was the most likely from the get-go? Again, I'm going to hinge on the fact that there's not a lot of differentiating factors in this case, but that it's 77% likely from the get-go. There's hemolysis and repeat infections can occur. So my diagnosis is Plasmodium falciparum, which is the most common vector or the most common microbe in Senegal. And the diagnostic test would be a thick and thin smear.
Thank you very much, Dr. Sastry. That was genuinely very fun to go over your breakdown of the case. I'm very honored to introduce our expert speaker here, Dr. Sangeeta Sastry. She's the director of the Antimicrobial Stewardship Program for VCU Hospital, and she's the associate professor of medicine in the Division of Infectious Disease. She's also the director of education faculty development and performance improvement for VCU's HIV Ryan White program, and also the Associate Chair for Clinical Education for the Division of Infectious Diseases here at VCU. In addition, she's heavily involved in medical school education and ID clinical care. Please welcome Dr. Sastry here.
So I get the easy part of this because I came into the case and the diagnosis was already made. I have to commend you on your tremendous presentation, your diagnostic reasoning. I know you just started as a nephrologist, but you may consider ID as your second career. All right, so let's talk a little bit about this. So what were the key elements of the case from an ID perspective? And the key ones definitely was the returning traveler that always gets us excited in the ID world. High-grade fevers. I know the initial one was like 38, but then by the time I saw the patient, it was like 39.4. He was ill-appearing on exam, anemia, thrombocytopenia, abnormal LFTs, and renal failure. So those are the key points that I picked up when I saw the patient. And then Dr. Street kind of alluded to, where Senegal is. And every time we have a returning traveler, we always go back and see, kind of where this actually is. I mean, we knew that it was West Africa, but it's good to always look at a map to see exactly where that is. And then next thing what we do in ID is look at what are the particular travel alerts in that particular area. And we do have a website called the TravX website that a lot of travel medicine folks do use. And then you have to register for it, et cetera. And you just basically type in that particular region and, where the patient person has visited. And then it gives you sort of a list of infections, et cetera, in that area. And especially for travel medicine, it's important. So if you want to be giving vaccinations, et cetera, then you could potentially look at those. But then for those who do not have access to the TravX website, you could definitely do CDC. CDC has a very good, is a very good resource for a lot of us in ID. So what are the infections in Senegal? I'm not going to go through all of this. Again, Dr. Street kind of talked about this, but this is an alphabetical order. But some of the preventable and non-preventable. But as Dr. Street said, when you hear this case, what's the first thing you do? You get that blood parasite smear, right? And it was, they did get it pretty much within the first 12 hours of the patient hitting the ED. And then this is the thick smear that was done. And it's kind of hard to see over here, but there are some parasites there. And then this is a thin smear that was done. And you can see that there's some intra-erythrocyte parasite over here. And this is, it has like what we call a sort of a delicate ring here along with a little dark center. And so that was one of the parasites that's seen. So everyone probably knows what this is. But if you want to look at a more characteristic finding is this particular banana-shaped gametocyte, right? And so our diagnosis is malaria. All right, and then and one of the, so very good, Dr. Street, well done. All right, so and then we actually do, and I'll talk about it in our diagnostic section, but we do an antigen on the patient as well to kind of give you what the presumptive plasmodium that we're dealing with, and it was positive for Plasmodium falciparum. And this is actually the actual patient, the smear on that I got from our microbiology folks, Dr. Bryson and Dr. Dorn. All right, so this was our final result here. This patient had 4% parasitemia with Plasmodium falciparum. So a lot of you probably know about malaria, have heard about malaria, and have treated patients with malaria. So this is not meant to be a very comprehensive sort of discussion here because we do only have 5 or 10 minutes here. But basically, we know that there's various parasites, Plasmodium parasites. Plasmodium falciparum is the one that's most common. And then we have others as well. And it's basically transmitted by the female Anopheles mosquitoes. And it's like, why only female? It's because the female is the one that actually uses, feeds on blood versus the male that actually feeds on plant juice. So that's how it's transmitted. And then we have a pretty significant amount of cases in the world. Per the recent statistic in 2022, around 250 cases, and 94% of those cases are coming from Africa. With a death rate, which is, it's nice to see that's less than 1%, but it was higher at one point. And in the US, we actually see around 2,000 people per year diagnosed with malaria, and most of them are travelers. We do have some that have had local sort of acquisition of malaria, and that's more in the Plasmodium vivax more than the falciparum here in the United States, but very limited number of cases. So malaria in Senegal, as Dr. Street said, that Plasmodium falciparum is one of the most common or mostly seen there, and the transmission is throughout the year, and really anyone going to Senegal should be getting chemoprophylaxis. And the patient actually said that, told the team initially while during admission that he did take chemoprophylaxis, but when we asked later on, he actually said he didn't. He goes there so often that he doesn't take prophylaxis. Yeah, 5 minutes. All right. So this is a life cycle of malaria. You guys can see this. I'm not going to go through this since we only have 5 minutes left. There's a mosquitoes part of it, which takes around 1 to 2 weeks for this life cycle to go through. And then when it gets into the human, it takes like 1 or 2 weeks for it to mature and therefore cause infect the RBCs. Some of the symptoms of malaria were the symptoms that the patient did have with fevers, muscle aches. The more severe ones, the ones that cause cerebral malaria, are the ones who are going to have more impaired consciousness, seizures, etc. So this is the malaria diagnostics that we do here at VCU. And so first we do a thick and thin smear. So when you send that over, microbiology is going to be looking at these thick and thin smears. The thick smears really is for just like to pick up the parasites. It's the thin smears that help you the most. And that gives you the ID it helps you give you the morphology of the plasmodium, but also kind of gives you the percent of parasitemia. And then we also have the rapid antigen test, which again, it's not very good with sensitivity, but it gives you an idea of what potential plasmodium you're dealing with. And then once we have a positivity here, it actually is sent to the state health department, and they actually do genotyping PCR testing on that and actually give you a final result. And here at VCU, it's actually pretty good, and we haven't had any mismatch in the diagnoses. So once you hear a positivity for malaria, of course, you're going to call your friendly ID doctor and find out, what next to do. But there's a CDC hotline that you can use that's available 24/7, weekends, weekdays, et cetera, that you can call and get some information to provide guidance. And the guidance is basically to be able to help sort of figure out if this is a severe case of malaria that you're dealing with, because the fatality rate can be pretty high. And these are a couple of the diagnostic criteria for severe disease. And then you go through the algorithm. Again, I'm not going to go through this. This is a CDC, it's on the CDC website. It's a pretty fairly self-explanatory. You just go through the algorithm to tell you sort of what treatment that you do for what kind of plasmodium that you're dealing with. But I did want to talk about treatment of severe malaria because that has changed recently. So what is the traditional one that you all are familiar with for treatment of severe malaria? Quickly, just someone. Quinidine, right? So that's what we were using for the longest of time, right? Up until May of 2020. So we're using this for a long time, but as you know, that quinine or quinidine has a lot of toxic effects, and that was the reason why, they stopped manufacturing it. And so our cardiology folks will probably talk about some of the cardiotoxic effects and hypertension related to it. Then also we were seeing some resistance to quinine, so not the best treatment for malaria anymore. And what really sort of changed the treatment of severe malaria was this discovery of artesunate. Not going to go through the details of this, but I just want you to know that the person, artemisins, or that was actually derived from a plant product, and that was in China back in 1960. But the scientist who actually translated that plant product into what we're using right now, the water-soluble product, actually won the Nobel Prize for physiology and medicine. That was in 2015. So I thought that was interesting for you all to know, and really helped reduce the global malaria fatality rate by using this medication. And then, there were studies, these are landmark studies that were done with using or comparing IV artesunate versus quinine. And there were 2 studies, one big one, and big in our ID world is like 1,000 patients, not like the cardiology 10,000. And so this was published in the Lancet, both in the adult population as well as the children population, and they found a pretty significant reduction in mortality. So when actually there's a beautiful editorial that's written in the Lancet in 2023 by Dr. Conrad Keating. from Dublin, and he wrote this. He kind of describes this whole like how artesunate was actually, founded, and how everyone was so excited. And apparently, when this was presented in the American Society of Tropical Medicine, there was like a standing ovation. Everyone stood up and said, "This is like the best thing ever," because it definitely reduced mortality. And then we know that artesunate is actually safe as well. So the CDC actually collected a lot of this data, that they were actually providing artesunate to patients throughout the country from April of 2019, even before the FDA approved it. So they were doing it under IND. And so we were getting a lot of the patients that we treated during that time. Actually, we had to call the CDC to get this medication. And they have a good cohort of these patients, so they can actually see if this is actually a safe drug. And they actually found that it was pretty safe. But interestingly, that the adverse events that were noted while giving this medication was actually post-artesunate delayed hemolysis. So there was actually delayed hemolysis by using this medication. But the good news was that a lot of these patients did not have any, they were recovered from this hemolysis even after getting the medication. So, the number was low as well. All right, so really this is RV artesunate is, IV artesunate is recommended treatment for severe malaria since 2010, but really it was, like I said, the FDA approved it in the United States in May of 2020. And so we actually have it added to our formulary at VCU since 2022, which is great to have that resource, because as I said before, we actually had to call the CDC to get that stock in our when we got a severe case. So going back to the case, this patient actually was considered borderline severe malaria. So he had all those things that were sort of like the anemia, the thrombocytopenia, the parasitemia, like 4% versus 5%, considered severe. So we actually went ahead and gave him IV artesunate. And then his parasitemia sort of became zero after that. And then as you can see, his discharge labs actually improved as well. So some of the take-home points, just as Dr. Street said, when you have a patient who's returning from especially a malaria endemic area, the first thing you need to do is get that blood smear. And then when in doubt about the diagnosis and treatment of malaria, phone a friend, call the CDC, has good resources. And then, of course, IV artesunate is there here on our VCU formulary. But if you do give it, make sure that you follow the patient for at least a month thereafter to check for CBC, hemolysis, as I mentioned. And then you also have to follow up with long-acting treatment. Again, we don't have much time left, so I'm not going to go too much into the detail. I want to thank my fellows who helped me with this case, and of course, our microbiology directors and Dr. Ching.
Thank you so much, Dr. Sastry. Now, for a few minutes that we have left, I would like to open for questions from the audience. Does anyone here first? Let's take questions from the venue. Does anyone have any questions to our experts here? Let's see if we have anything over Zoom. So we have a question about the clarification of the hyperbilirubinemia type and severe malaria.
Can you please clarify the question, please?
So it says here, on particular site count determines the patient had hemolysis. I'm not sure what Dr. Kolipakum means by his question here. Do you have any questions from the audience here?
Sure, I'll ask. Great case, Ramez. Question for you. What was the cause of the, I'm guessing it's bilateral neuropathy, or like 3 months?
So the question was about the bilateral median neuropathy. My impression is that so the patient does have a history of peripheral neuropathy, and this is part of his chronic disease. So it was kind of red herring for the case here.
had a late night leprosy panic though. I got it. I had a late night leprosy panic.
We have a question here from the Zoom. Does this smear need to be performed at any particular time during the patient presentation?
The earlier the better. The earlier the better. Yeah. And send that smear ASAP to the lab. Don't let it sit around because that could mess up the looking at it, morphology, et cetera.
Thank you. Another question that we have here, when do you recommend that travelers see a travel clinic provider before travel? And is that available outside of an academic center?
Yeah, I would say well in advance. So probably at least maybe 3 months. Is that what my ID folks would say? If you know that you're traveling to some area because you want to be able to give the vaccines that's required. Maybe if there's a second follow-up in 4 weeks that you could probably do that. So I'd say at least 3 months in advance, probably go to your travel medicine. And most academic centers have it. I don't know of any, well, there's not a lot of ID practices left out there that are non-academic here in the Richmond area. But do we know of any? I'm looking towards my ID colleagues at any private travel medicine. Okay. Yeah, getting the vaccines, but I mean, if you want a specialist, then I think most of it. Okay. So apparently there's a thing called Passport Express that could potentially give you some of that advice on travel medicine.
A lot of the vaccines are covered by insurance.
So Dr. Berman, you're saying travel vaccines are not covered by insurance? Gotcha, gotcha. All right. I think our time is up here. First, thanks so much for the audience for being here, and special thanks to Dr. Sastry and Dr. Sastry for going through the case.